Right, hello, kia ora everyone, and welcome to the Goodfellow webinar tonight discussing Maviret, the new treatment for chronic hepatitis C, with our guests Dr. Ed Gane and Dr. Richard Davies.
Thanks, Vicky, and good evening. Thanks for dialing in. It's almost 3 years since I gave a webinar on treatment of hepatitis C, and that was immediately after the government funded the first non-interferon treatment, which was a step, although as many of you will know, that's quite a complicated regimen, and it only treated one type of hepatitis C. And a huge change has happened on the 1st of February, in that we, for the first time, have a very simple one-size-fits-all treatment for you to offer your patients. And over the next hour or so, Richard and I will hopefully convince you that primary care will largely eliminate hepatitis C from this country within, I think, a decade, possibly sooner. I'll just give you some background. First of all, you all know about what a huge progress we've made for managing HIV and preventing AIDS. These are data many of you will know well, and that over the last 25 years, the mortality from HIV in this country has reduced by 99%, from almost 75 people dying a year to less than one a year in 2017. And that's thanks to better awareness in the general public and in primary care about HIV, better testing for HIV in at-risk groups, and a huge advance in treatment so that life expectancy now is almost normal. But if you look, we haven't achieved anything near that in hepatitis C, and now the mortality from hepatitis C in this country is more than 100-fold higher than that from HIV, and is climbing steadily every year. And that really reflects, I think, the lack of awareness, the lack of testing, and the suboptimal treatments we've had to offer people with hepatitis C up until this year. This is my day job. I work at the liver transplant unit at Auckland City Hospital, and we have seen hepatitis C become far and away the most deadly type of liver disease in this country. It's a leading cause of liver transplantation, and it's a leading cause of liver cancer. If you look at the graph on the right, these are the numbers of people who are diagnosed with liver cancer from hepatitis C each year, and that's increasing at between 10 and 20% per year. Why this is such a dramatic consequence is that once you're diagnosed with liver cancer, the average survival is only 3 to 4 months. So this is really a devastating complication of untreated hepatitis C. And a very important study which came out of New York City, looking at complete mortality data over a decade, they showed that people with hepatitis C live 18 years less than people who do not have hepatitis C. To give you an idea of what an impact this has on someone's life expectancy, and it also has an effect on someone's quality of life because of the symptoms associated with hepatitis C. When the new treatments came into being approved and being funded around the world, it became clear that we could cure almost everyone with hepatitis C. And in 2015, the World Health Organization announced that hepatitis C would become one of the 9 infectious diseases which could be eradicated across the globe. And they set out targets to be achieved by 2030. And 194 countries, including our own, signed up to achieve these targets. Just in brief, you can see that what the targets include with these new treatments, we would reduce the incidence of hepatitis C, cases of new infection, by over 90%. We could also reduce the numbers of people dying from hepatitis C by 2/3 if we were able to roll out treatment. So when we look at how we're going to achieve that, the questions which are so important is, how many people actually have hepatitis C? We do not have a registry for hepatitis C in this country. Chronic hepatitis C is largely a silent disease, and it is undiagnosed, and up to half New Zealanders living with hepatitis C. So what is the total number of people we have to treat if we are going to reach these targets and if we are going to eliminate hepatitis C? The Ministry of Health used an ESR report in 2000 with a bunch of public health and epidemiology experts and international experts to try and work out the total numbers of people with hepatitis C in this country, and they came to the figure of 25,000. 25,000 people, about 0.5% of the population. And they did disease modeling to work out how many people would die each year after 2000. We looked back at this in 2010 and found that this model underestimated the numbers of people we were seeing dying from hepatitis C or developing liver cancer by 50%. So we know that that estimate was far too low. And the current estimate, or the working number we use, is 50,000. And that's based on another epidemiology working group, which I was lucky enough to chair. And they came up with using some prevalence data, and by assuming that we have a similar epidemic to what they have across the Tasman, that 1.1% of our population are living with chronic hepatitis C infection, which will give us a number of about 50,000. So that is our estimate of the total number of people infected across the country. And we don't think that the prevalence differs whether you live in Kaitaia or if you live in Bluff. I won't talk too much about how people are infected. You should know that the vast majority are infected in their youth from injecting drug use, even if they inject only once. And most people living with hepatitis C have been infected for 20 to 30 years without any specific symptoms or testing. How many of those people remain undiagnosed? And this really is going to be the next big step. We have wonderful treatments. How are we going to find people and treat them all? We have two sets of data which have recently become available. Arlo Upton, who used to be microbiology head of the community labs, did a collaborative study across all the community labs across New Zealand and found that 28,000 people have had at some stage a positive antibody test for hepatitis C. 28,000, that's potentially 28,000 out of the 50,000 denominator. Around 50 to 60% therefore should have had a positive test. We've got some data for what we call a linkage study, where we've looked at all the people who come through to our National Liver Cancer Service. They're all referred to a single multidisciplinary service at Auckland Hospital. At the time we analysed this, there were over 600 people who had been diagnosed with liver cancer from hepatitis C. I must say the numbers continue to climb, and since we reported on this in December, we've had more than 50 new cases. Now, of those 600 cases, 40% of them, the diagnosis of cancer was made prior to the diagnosis of the hepatitis C infection. So that tells us that people are getting sick from the complications of hepatitis C before the hepatitis C is diagnosed. So we think overall around 40 to 50% of people living in this country with hepatitis C remain undiagnosed. So somewhere between 20 and 25,000 people, most of whom are in their 40s, 50s, and 60s, are living normal lives, living with hepatitis C, really a waiting time bomb to get complications. How many have been treated? Well, I think up until recently, the numbers were pathetically low because of the problems with interferon. You may remember me talking about interferon at some of the CME meetings. It's an injection you take either 3 times a week or once a week, and it causes flu-like symptoms. It has a cure rate of only around 20%, and people feel sick for the duration of treatment and often end up with psychological effects which are long-lasting. So the uptake for interferon was very, very low. When Vicarapac was first funded by Pharmac, and that was July 2016, the numbers starting treatment went up around 20-fold immediately in the first year. So we had the first oral treatment where you weren't having to take this poorly tolerated interferon, and the cure rates went from 20% to almost 96%. So that had a dramatic effect in 2016. So we know, all in all, since July 2016, 3,200 people have been treated with Vicarapac. around 40% of them have been treated by GPs, and that's very important, and I'll come back to that. In addition to those, another 2,000 people have been cured in some of the trials we were lucky enough to participate in both Christchurch and Auckland, where we had large numbers of people enter clinical trials. And another 500 have been historically cured with the old interferons. So we think around 45,000 people are still infected, what we call RNA positive, and these are the people we want to find, and we want to treat them, and we want to treat them in the community. Unfortunately, I pointed out how high the numbers were being treated with oral treatment after July 2016. This was when ViCuraPac first became funded. This is all oral treatment. You have to take about 8 to 9 tablets a day in split doses. You do take it for 12 weeks. There are some side effects because people take a drug called ribavirin. But regardless, it was quite a complicated regimen to use. It was prescribed widely for the first few months. And as I mentioned, the cure rates were very high, 96%. But you can see what's happened after the first few months of enthusiasm, that the numbers being treated each month have declined pretty steadily over the next 2 years. So we got down to the end of last year, only around 30 to 40 people were being treated a month. A fraction of the 250 people being treated per month for the first quarter. And there are many reasons for this. But one of the most important reasons is this ViCuraPac, remember, only cured one type of virus called genotype 1. So everyone out there who had other genotypes didn't have an effective treatment. The other issue was all the genotype 1 patients who had been waited for treatment, who were diagnosed, were started on treatment as soon as they could be. And so we ran out of people to treat, both in the hospitals and in the community, because we weren't diagnosing new cases. We weren't making new diagnoses of people who were living and who were undiagnosed. So how do we increase treatment uptake again? We have to find the undiagnosed. That's, as I mentioned, the 20 to 25,000 people who still haven't been made aware of the hepatitis C infection. We need to improve linkage to care, and we need to access the newer, what we call pan-genotypic treatment, or Maviret, which can be used to treat everyone regardless of their genotype. Finding the undiagnosed. Well, this is what you're going to hear a lot more about over the next few months, is how do we target testing for hepatitis C? I've mentioned the #1 risk factor for hepatitis C transmission in New Zealand, as it is in most countries, is previous injecting drug use. And if you target this as your main risk factor, it will work extremely well in the high risk groups where people are still injecting. I include there the needle exchanges around the country, the opioid substitution services, and certainly community alcohol and drug services, which include a lot of people with a history of injecting drug use. We've relied on this targeted testing, and this poster on the right of the slide is a poster which has been used widely across the Auckland region on the back of buses to really raise awareness of the risk factors for hepatitis C. Now, if you look at those risk factors below the stickmen, you can see these are all risk factors we associate with hepatitis C transmission. Ever injected drugs? Ever, even once? Have you ever been in prison? Have you ever had tattoo or piercing? Now, prison and tattooing go hand in hand with using unsterile equipment and possibly transmitting the virus from one person to another. Tattooing or piercing in a licensed parlour is not a risk factor in this country. It's only tattooing with unclean or reusing tattooing equipment, which is by default how most tattooing is performed in prisons. Blood transfusions were a risk factor, but almost everyone who received a blood transfusion prior to 1992 has been tested through the look-back programs and have been treated now. And we've included other risk factors such as ever been jaundiced in the past, ever lived in countries with very high prevalence, and this includes Eastern Europe, Russia, much of Southeast Asia, the Middle East, and the Indian subcontinent. These countries all have rates of hepatitis C 5 to 10 times higher than New Zealand. And in these countries, you can transmit hepatitis C through ways other than blood transfusions. You can have unsterile needles used in vaccinations and many other potential iatrogenic sources. And of course, if a woman of childbearing potential gets infected with hepatitis C and then has children, there is a small risk of transmitting the virus to the newborn baby. That risk is around 1 in 20 or 5%. So these are all risk factors. Targeted testing, unfortunately, has not been very successful in this country. We've been trying it now for a number of years, and it really fails. And the reason it fails is because of the stigma associated with admitting these risk factors, in particular, admitting previous injecting drug use. And we think that's been a major barrier to getting people to come forward to get tested.
Ed, if I can just interrupt you
Yes.
quickly to ask about the poster. Some good feedback. Can we get hold of that anywhere, or is that available?
Yes, it's Mike Wilson at the NRA can arrange to provide it to all the PHOs, and that's Mike's job really, is to interact with the PHOs.
Oh, excellent. Okay, so we might follow up with some information. About
and this is what we're using currently. It's going to change.
Okay, excellent.
Birth cohort testing has been advocated. This is what they do in the US, and this is based on the so-called Woodstock or Vietnam War era, when people came back from the war, and there's an enormous influx, as you know, of opioids, heroin in particular, across the states. But I should say that's about to be abandoned by the CDC, because they realized that the epidemic wasn't 20 years. The epidemic is ongoing. And that poster I show on the right, unfortunately, is a stark reality of what's happening in the US now with the opioid epidemic. And that's led to a dreadful increase, as you're probably aware, of deaths from opioid overdoses. Over 75,000 people dying in the US in last year from this. This opioid epidemic has led to a marked increase in hepatitis C transmission over recent years. And unfortunately, that's happening in other Western countries. It's starting to happen in Australia, and no doubt with time it will hit our shores as well. Universal testing is something you will hear a lot about. Universal testing means just that. You test every adult for hepatitis C. It will only be promoted in this country if we have cheap diagnostics in the National Registry, and this is what the government is currently working to evaluate whether we can roll this out. It is being used in a number of countries at the moment, and these are the countries which are actually eliminating hepatitis C. The idea of having universal testing and the registry combined is that you don't keep on testing people who you already have been tested, so you don't double or triple the costs. And the other point of the registry is you link everyone who's newly diagnosed with treatment. This treatment is so easy. And once they've been treated, they can come off the registry. So these are the things which are being worked through at the moment by the Ministry of Health. Okay, the other thing which certainly GPs around the country are being asked to be involved in is the Look Back program. I'll talk a wee bit about finding those who are already diagnosed but lost to follow-up. And lots of people were diagnosed over the last 20 years. I showed you 28,000 people have had a test. Many of them, though, have either declined interferon treatment or have just moved and been lost to follow-up. We're cleaning out our hospital databases and have been for the last few years. And we're actually referring people without cirrhosis back to their GPs so they can start Maviret. There is an audit tool developed by your college which can be applied to your patient management systems to find anyone you've tested in the past and to recall them now to start them on treatment. The new initiative, which has been rolled out by the ministry, by Pharmac, I should say, is a primary care hepatitis C look back program, which started around 6 months ago. And the point of this is to check all of those 28,000 New Zealanders who have been diagnosed as hepatitis C positive and find out where they are. Have they ever been treated? Are they still infected? And if they are, send them back to the GP who ordered the test, or if it was somebody in needle exchange or another community provider, send them back to them so that they can be started on the new Maviret treatment. The PHOs have all been sent details of how this is going to happen. I pointed out that's a denominator just to go through this. A number of people have, so these 28,000 people have now all been cross-checked through the NHR system. Those people who have died or have never had the NHR, who have left the country, have been excluded. Those people who have been treated or were never infected, cleared spontaneously, have been removed. So we're left with just over 9,000 people who are untreated. That's a big number of people whom we could cure very quickly. And of those, around 400 came from community alcohol and drug services or needle exchanges or sexual health, and they've been referred back there, and from then back to their GPs. But almost 8,500 people are being referred across the country by Pharmac back to the PHOs and back to the primary care provider for that person. And so you'll be hearing about these. Every practice will have an average of 2 to 5 people, we think, who will be picked up through the look back, whom you may hear about. Once you've diagnosed somebody, then you want to link them to care. And of course, the best place to do that, I don't have to tell anyone on this webinar, is to do this in primary care. And that's the big incentive for Pharmac to push treatment and to fund these new easy treatments so that we can provide treatment in the community. And it's been very important for some of the certainly for Vicarapac, which is a complicated drug because you have to worry about the other drugs, the other comorbidities your patients have, and the most up-to-date records of those are kept in primary care. I'll come to the reduced costs a bit later on because there are some, I think, exciting incentives which have been provided. But the main reason we're so keen to get you as primary care providers involved in treatment is to help you engage in increased awareness and increased testing in your practice. And we've had a lot of feedback from patients when they tell us. We offer them going back to their GP for treatment. When they've been in our clinics, they say they'd much rather be treated there. They find it not only is it cheaper, but it's far less discrimination, they feel, than sitting around in hospital clinics waiting to be seen and discussed. Some things are changing in the algorithm for treatment. We've got a simplified diagnosis. At the moment, we do reflex testing. By that, I mean you send off a single blood test, you write on the form at risk for hepatitis C for testing, and if you live certainly in the northern region, you will have reflex antibody and either antigen or RNA testing off the same blood sample. There are some newer things coming aware. This is a new platform from Abbott, which we hope to have operating by the end of this year, which instead of RNA testing, which has to be sent to a hospital, your community lab can do antigen testing, which confirms active infection. So you do a simple blood test off your patient, you send it to the patient that is taken at the community labs. They do the antibody test on this big machine here, and that machine will use the same sample at the same time if the antibody is positive to check for the virus, called the antigen test. Genotyping is not necessary anymore because Maviret is pan-genotypic. So suddenly from having 3 different blood tests, you have a single blood test, and you get the information about whether your patient has active hepatitis C, and if so, you can treat that patient with that one-size-fits-all regimen. The other thing which is changing is, first of all, we stopped doing liver biopsies many years ago and moved to FibroScans. We now have an even simpler way to determine whether somebody has cirrhosis, and that's with a blood test called the APRI. APRI stands for AST-to-Platelet ratio index. And you're going to hear more about APRI from your labs. APRI means you can decide whether or not the patient has cirrhosis on a blood test at the same time as you're determining whether they have still have active infection. APRI is based on the premise that people with chronic hepatitis C get increasing damage to the liver, we call fibrosis, which eventually causes cirrhosis. And as the liver disease progresses, the AST level goes up and the platelet count declines. And so it's a combination of these two markers are very, very good indicators of how severe that person's liver disease is. And it's very well validated for hepatitis C. It's a simple online calculation which you can access. And links to that are included in the health pathways and on BPAC. But you don't even have to do that. The community labs, lab tests, and are looking at providing the APRI score for you. If you write on the blood test form APRI, they will make sure that the right blood tests are done, and then they will send you back the score. So how do you interpret the score? Well, it's pretty simple. If the APRI is less than 1, then you know that that person does not have cirrhosis. If the APRI is more than 1, then they may have cirrhosis. They don't all have, about half of them will have cirrhosis. So if the APRI is less than 1, which 80% of patients will be, you just get on and treat them for 8 weeks. If the APRI is more than 1, then they may have cirrhosis and they should be referred for a FibroScan, because if they have cirrhosis, then they need 12 weeks of treatment rather than 8 weeks. The APRI score is very easy and it will replace the need for FibroScan in most patients with hepatitis C, and it should speed up your decision to start that person on treatment. So you do a single blood test to confirm infection and a single blood test to tell you whether or not the person has cirrhosis. So whether or not they need 8 weeks if they don't have cirrhosis, or 12 weeks treatment if they do in fact have cirrhosis. As I said, there's an APRI request form. Gary, the lead for lab tests, is devising, which should become available to you in the next month or two in the northern region. But we'll try and roll this out nationally. Now we'll come to talk about really the biggest advance, why we're even talking about eradicating hepatitis C, and that's because treatment has become so simple, so uncomplicated, that it's a perfect treatment for community prescribing. In the next few slides, I'll tell you, first of all, how successful this treatment is, and then how you can prescribe it. So it's a drug called Maviret. Maviret is a trade name, and it combines 2 antivirals in a single tablet, what we call a protease inhibitor, glecaprevir, and an NS5A inhibitor, pibrentasvir. These are the final drugs ever to be developed for hepatitis C, because it really doesn't get better than the results you can achieve with this. Maviret was approved about 1.5 years ago by the FDA from a large number of studies, what we call phase 2 and phase 2 clinical trials, which included 2,300 patients. It's now approved in New Zealand for the treatment of adult patients with chronic hepatitis C, no matter what type of hepatitis C they have, whether or not they've had cirrhosis, and whether or not they've ever been treated before. So it's a universal treatment. So what did the clinical trials tell us? It told us almost everyone was cured. Overall, 99% of those 2,300 people treated with Maviret, with genotypes 1 to 6, were cured after 8 weeks of treatment if they did not have cirrhosis, and after 12 weeks if they had cirrhosis. The cure rates were the same. The lowest cure rates were seen in genotype 3, but even in genotype 3, if you looked at the people who completed their 8 weeks of treatment, it was just under 99% were cured. So all in all, this is a very effective treatment after only 8 weeks. So that's clinical trials. People say, well, that's clinical trials. They're being followed every week. They have nurses phoning them every other day. We know that they're going to be the super adherent patients. What about when these drugs are used in the real world, when people start prescribing them in their general practices or in their clinics. This particular drug has been so effective and so successful that it's replaced all other drugs for treatment of hepatitis C. And there are now many tens of thousands of people who have been treated in the real world outside clinical trials. I'll just show you the initial results presented last year from Germany and Italy. And if you just look at those figures on the top of the bars. So even in the real world, outside clinical trials, you're getting well over 99% of people are being cured. So this really is very effective and very safe treatment. I mentioned there are 2 antivirals co-formulated in the single tablet. The recommended dose is 3 tablets, shown here on the left. You take once a day with food. So 3 tablets once a day, and it comes in little blister packs for each day. There's a weekly carton, and then there's 4 cartons in a monthly carton. So patients can be dispensed the entire 8 weeks treatment, and that will have 2 boxes of these, 2 of the large boxes, which include 8 weekly cartons, and all of these will contain 7 of the daily blister packs. Before you start treatment, you need to know what other medications the patient is on, and you'll be aware of what other medicines they're on, because there may be some medicines which could be interfered with by the Maviret, or vice versa. So drug-drug interactions with this combination are few compared to the old Bikera pack, but there are a couple you need to know about. There are a couple of drugs which need to be stopped for the duration of treatment or switched. You never need to change the Maviret dose. It's always 3 tablets once a day for 8 weeks, but you may have to stop or switch one of the other medicines a person's taking for their blood pressure or for their high lipids. For those of you who ever prescribed Bikera pack, these were all the contraindicated drugs with Bikera pack. And when we switched to Maviret, those numbers of drugs interactions largely disappeared. There are only a couple of drugs you need to know about, you need to be aware of, and we'll come back to these in some of the clinical cases later on. But really, the drug-drug interactions are very similar and are very simple for this regimen compared to the old Bikera pack. What about patients who are currently using recreational drugs? Can there be significant boosting of their recreational drugs or of their methadone or their buprenorphine from Maviret? Well, as you can see here, there's really no significant interactions with any of the commonly used recreational drugs. There's a potential interaction for GHB, although that's minor. So this really is quite a safe medicine to use in people who are still using recreational drugs. How do you check?
You know, I was just going to mention, someone's asked about alcohol in terms of interactions.
There is no known interaction between alcohol or Maviret. Alcohol doesn't affect Maviret's effectiveness, and Maviret doesn't boost alcohol. So alcohol, we say to people who have significant liver disease or cirrhosis that they should stop all alcohol. For other patients, we would say to moderate during treatment, but there is no interaction between alcohol and Maviret.
That's great.
Yeah. It's very simple to look up potential drug-drug interactions. There are a few, and we'll come back to them in the cases. The best website is actually the website on the bottom, what we call the University of Liverpool website. Again, the link to that is in the BPAC guidelines and in the health pathways online. You can also download a mobile app for your device or your phone if you wish. It looks a bit like this, and it's very simple to use, and we'll come to some examples a bit later on. You just put in Maviret and then you click on the particular drug you're worried about, and it will come up as traffic lights, either green, no problem, orange, you may have to change the dose, or red, stop or switch. And you can actually, if you look at using this, you can use this website to switch to another drug in the same class or same indication, which is safe to use. But as I mentioned, the number of drug interactions with Maviret are very, very few compared to Vicarapac. Okay, Maviret should improve treatment uptake, and 99% cure across all patient populations, no matter what type they have. It's very simple. Once daily dosing, none of the old ribavirin, which made people feel tired. It's very simple for you to start treatment. You don't have to do any of the RNA quantitation levels, any genotyping. You can use the antigen test soon. That's coming to lab tests. It's very simplified on treatment. I mentioned few drug-drug interactions you can check online. No on-treatment monitoring is required. So you can see your patient, you can prescribe the 8 weeks of Maviret, and then you can bring them back or give them a form to have a blood test 12 weeks after they finish treatment to show whether or not they are cured. And there's some question I often get asked, what if the person doesn't come back for that test? What if I give them the 8 weeks of treatment and I never see them again? In fact, in reality, almost all of those people will be cured. If they do relapse, a lot of their symptoms of fatigue will come back and they'll represent. So although we recommend that you give your patient a test to check that they're cured 12 weeks post-treatment, if they don't have that done, it doesn't mean that they haven't been cured. 99% of them will in fact be cured. So this is a very, very simple regimen to prescribe and to supervise. Now, I mentioned to you that it's important that we roll out this treatment to general practice. Before 2016, almost everyone who received interferon were treated in hospitals. And that was understandable. That was a complicated treatment, had severe side effects. You can see over the course of Vicarapac funding that treatment rates, the proportion of people treated in general practice has risen pretty steadily to around 50% by the time we moved from Vicarapac to Maviret. So that's 50% using quite a complicated regimen. One thing which I think you should know is that the results achieved in general practice prescribing are as good as those which were achieved in hospitals. This is data from those people who have been treated with Vicarapac. And this was a lot of work where we got data from Pharmac, from everyone who had been prescribed Vicarapac, and we traced their post-treatment results to see the cure rates. And we worked out, Pharmac told us whether they were treated by their GPs or whether they were treated in the hospitals. And you can see the overall cure rate with Vicarapac was 96%, but it was exactly the same whether they were treated by their GPs or whether they were treated by hospitals. And that, to me, is a real evidence that there's no advantage in people being sent to hospital for their treatment. Today, 90% of people living in New Zealand with hepatitis C are suitable for 8 weeks of treatment and can be simply treated in primary care. There are a few people we still recommend sent to hospital, people with cirrhosis and people who have failed previous treatments, but those numbers are being prioritized for treatment and are rapidly disappearing. Within the next 3 years, the vast majority of everyone left to treat will be without cirrhosis and will have never received interferon. So 98% of people living with hepatitis C within a few years will be suitable for treatment in general practice. So now some practicalities of how do you prescribe Maviret. First of all, you confirm your patient's hepatitis C. I mentioned you send off a single blood test. Does patient have hepatitis C infection? You confirm whether or not your patient has cirrhosis, and for that you need an APRI test, or you do an e-referral for FibroScan. You can check for potential drug interactions, and Richard will talk about a couple of important ones soon. You write a script. You send the patient to an APRI designated pharmacy, and the Maviret will be dispensed. Not immediately, it's still taking 2 to 3 days for that Maviret to be sent to that pharmacy. And then you do a post-treatment check for cure. We have lots of resources online. These have all been updated for you to use to walk you through the process of prescribing Maviret and how to find a APRI designated pharmacy. There are a lot of these pharmacies. There's over 350 pharmacies across New Zealand who are APRI designated pharmacies. Here is a map just showing the ones around Auckland, and you can find the simplest one. And more pharmacies are being opened up every day to dispense Maviret. Pharmacies do get reimbursed for this, so they're very keen to enter the program with APRI if you have suitable patients. There are some incentives to facilitate uptake. There's no pharmacy dispensing fee for Maviret, so the patient doesn't have to pay the $5 fee. Many of our patients have community services cards, so they do have reduced cost of visits. There's also a one-off payment for patients who have a community services card through WINS, where they can get a one-off special needs grant to help them with any part charges for their GPs, any transport, any other ancillary expenses, which will help them get through their course of Maviret. And if you live in the northern region, there is a POAC funding for you. For every patient you start on treatment, you can apply for $100 reimbursement from the NRA, and your PHO should all be aware of that. That is being rolled out across other DHBs, but as far as I'm aware, it's not through all DHBs throughout New Zealand. But it's certainly other DHBs are using a similar POAC payment scheme, which goes to the GP who treats patients with hepatitis C.
I wonder if we might move on to the cases.
I think so, yeah.
Yeah, if that's a good time. So we may ask you to just be with us while we exchange seats. So we have Dr. Richard Davies come to the fore, and we'll go through a few cases from his work as a GP at the Auckland City Mission.
Thank you, Ed and Vicky. Good evening, kia ora to everyone. I was in the UK last year and had a chance to sit in on a couple of hepatitis C clinics, and I was struck by the contrast between the approach there and the approach here. They have a very complicated approach to try and drive down costs. So every genotype gets a different regime. Only hospitals prescribe, and only some hospitals prescribe, and so they have teams of community nurses running around trying to engage with patients and deliver drugs. GPs are very much uninvolved in the whole process, and it struck me that it was complicated, expensive, a bit piecemeal, and ineffective, a bit like Brexit. I would stress I'm not an expert in hepatitis C, but the practice I work in has a high prevalence. We've got about over 10% of our patients have hepatitis C, so we've had the opportunity to use Viekira-Pak and Maviret quite a bit, and I can say that Maviret is straightforward and not very time-consuming to prescribe. And I think those of you who've tried Viekira-Pak will certainly find it so. The real challenge, of course, is actually finding the people who've got hepatitis C, as Ed's alluded to. And when Viekira-Pak first came out, we did an audit of our patients to try and pick out those with hepatitis C, and it wasn't very satisfactory. There were very few who had a classification of hepatitis C. Quite a few had viral hepatitis, but of course that includes hepatitis B as well. Risk factors aren't you can't audit them. Trial results may not be communicated. Lab tests got fed up with us asking for hepatitis C patient tests on patients who'd already been diagnosed, and so they actually did an audit of all our patients, looked at the last 7 years' data, and to cut the long story short, about half we knew about half the patients to be positive who actually had previously been tested positive. And of course, that's before all the patients who've never been tested, which is probably another half. So screening is very important, and because we don't have universal testing available yet, we do have to ask about risk factors, and I would encourage you to ask about risk factors. I've only once had some cause defense asking about using needles. I think you can use things such as abnormal LFTs or piercings or other drug use to start the conversation. And of course, our nursing colleagues are very good at that. So if you've got your patient who's got active hepatitis C, and Ed's gone through this, you rule out cirrhosis with a FibroScan or with an APRI test. We check LFTs, blood count, HBV and HIV. We advise on risk management, particularly around the use of clean needles in people who continue to use intravenous drugs. But we have found that those who do use are very motivated to clean up their act and not to reinfect themselves. We need to manage the interactions. Again, that is much simpler than Viekira-Pak. That the big ones in primary care are the statins and steroids, including the oral contraceptive pill. Currently, we aren't using it in people who are pregnant or breastfeeding. And the tablet is the regime, as Ed has said, is 3 tablets a day for 8 weeks, or in some patients, those with cirrhosis or previously treated, it may be 12 or 16 weeks following consultation with the liver clinic. I haven't seen a lot of side effects. I had a patient recently with fatigue, but not badly enough to want to stop the medication. I haven't come across headaches or nausea. So if a patient has cirrhosis or has been previously treated or is positive has active hepatitis B, the advice is to refer. Some of our patients we find really don't like going up to the hospital, and so we have, following discussion with the liver clinic, we have actually treated them in general practice, and I'll mention a couple of those cases. So I'll go through some cases. The first patient is a 65-year-old man who used intravenous opiates in the 80s and 90s and was diagnosed with genotype 1A in 2011. He was offered the opportunity to have interferon, but decided against it at the time. His past medical history, he's had a TIA, and he takes aspirin and atorvastatin. FibroScan was done, which shows 7.7, so he's not cirrhotic. He's got slightly abnormal LFTs. So really the only thing to manage his interaction was that we stopped his atorvastatin for the duration of the Maviret. Ed showed the University of Liverpool interaction site, and so you type in Maviret and it comes up there. You type in atorvastatin and it tells you that do not co-administer. One thing I would say is that it's a UK website and it doesn't recognise brand names which aren't used in the UK. So, for example, Levlen ED, one of the combined oral contraceptive pills, won't come up. You need to type in the generics to get that to work.
Richard, how good is MIMS for interactions? Have you?
Yes, so yes, the link on MedTech brings up interactions. I haven't checked it conclusively, but it'll certainly flash up with the statin, for example. The statins vary a bit. I think pravastatin you can continue at half dose.
Half dose, yeah, that's right. Yeah.
So the second patient, it was a woman of 32 who, again, her main risk factor was intravenous methamphetamine, which she had, and she's been clean since 2016. She was diagnosed as genotype 3 in 2010, and she's been hanging out for Maviret to become available. She's on Levlen, norepinephrine, and levonorgestrel, as well as thiamine for her alcohol and salbutamol. She's got minimal fibrosis, slightly abnormal liver enzyme tests. She doesn't have hepatitis B. So with her, we stopped the Levlen ED. We gave her a progesterone-only pill and advised her to use condoms as well. And she was treated with Maviret for 8 weeks. The third patient was a little bit more complicated. He was a 51-year-old man who sustained multiple fractures, including a broken neck as a young man working as an acrobat, and became addicted to opiates during his medical treatment. He had genotype 3, which was treated with interferon in 2007, but in 2008 was found to have genotype 1b, and it was unclear as to whether this was a relapse, a reinfection, or whether the initial genotype had actually been correct or not. He'd hoped to get into a trial. He was another of our patients, very keen to be treated. He hoped to get into a trial but wasn't eligible. So he's another one who's been hanging on for Maviret and pestering us from last year to find out when it was coming out. He's on Suboxone, omeprazole, and diclofenac, none of which have significant interactions. His FibroScan he's not cirrhotic. His LFTs, his ALT is raised. So we discussed him with the liver clinic on the basis that he'd been previously treated and either relapsed or reinfected, and the advice was Maviret for 16 weeks, and so that was what we prescribed. And then the last patient continues to be a heavy meth, IV methamphetamine and alcohol user. Now this is a 47-year-old male. He was diagnosed with genotype 3 in 2014. He's an unfortunate man. He's had a very difficult life. He sleeps on the streets, and he's failed to attend a liver clinic on 5 occasions. His FibroScan is 26.6, which is significant cirrhosis. We haven't been able to get any recent bloods from him, but when we did get bloods, the LFTs were abnormal. And really, we felt there was no prospect of getting him treated in clinic. So we discussed him, and he is on a 12-week course of Maviret. So I've just got those 4 cases. Welcome any questions. Particularly welcome any comments as to why people might be reluctant to prescribe Maviret. As I said, I found it fairly straightforward to use. I think it's, I would say you could compare it with using the pathway for the sore throat algorithm, and it's certainly more straightforward than doing a cardiovascular risk assessment on someone from scratch and then discussing atorvastatin. The difference, of course, is that most of us don't have very many hepatitis C patients, so we have got to get our heads around it. But I think the real challenge is the case finding out who needs to be treated. I think the actual treatment is very straightforward.
There's a couple of questions just pertaining to this case,
Sure.
actually. One of them, just regarding the risk of reinfection.
Yeah.
You know, what do you guys do to follow up and ensure they're compliant? And then there's a second question that came in earlier, actually, about how effective the treatment might be if people are missing doses. So if you've got someone who may not be fully compliant, you know, how do you manage that?
Yeah. We in general, we find all our patients who go on to Maviret are really quite they're keen to get treated. We do help them with, we are able to help them with compliance in a number of ways. We have a great pharmacist next door who will do daily dispensing or weekly dispensing for rough sleepers. We're looking at the possibility of doing daily texts to get people in the habit of their medication. We haven't had any, we've treated now about 24 people with Viekira, and I think I did the 26th prescription for Maviret this morning. So it's a bit too early really to I'm not aware of any treatment failures. We have had one reinfection, but we do take the time to talk to people about reducing their risk factors, and in particular not sharing needles. A lot of our people who have been drug users in the past, have been intravenous drug users in the past, are no longer using.
So I think it is quite a forgiving regimen, Maviret, compared to Viekira Pack. So I think if the person does miss one or two doses but takes a majority of tablets, he or she will almost certainly be cured. I think we get a good indication from that, from looking at those real world results people are seeing across the world, where the cure rates in clinics and general practice are at least as good as those in the clinical trials. And certainly this is quite a forgiving regimen, I think.
Yeah, that's good to know, isn't it? Yeah. There was a question earlier about the decision to treat based on the APRI score, and obviously not everywhere, like the Calder Centre, has access quickly to FibroScans. I know you guys have that wonderful facility where people can come and have their scan. If you're in the position of having identified a high APRI score and someone needs the FibroScan, would you consider initiating treatment before the scan and then leaving the duration to be decided later?
The problem is if somebody completes treatment, or even halfway through treatment, the inflammation disappears. The liver test return to normal.
See. Right.
And one of the drivers of the measurement of what we call liver stiffness is due to that. So you can be cirrhotic, and once you're cured, your FibroScan will be normal. So it's impossible then to actually make the diagnosis of cirrhosis without having to resort to a liver biopsy, which we'd never do nowadays. So I think, but your question is, can you start treatment? What we're going to do, for example, we have a pilot in the needle exchange, and we're going to take off the blood test for APRI and start the person on treatment before we get the result, and then prolong treatment from 8 to 12 weeks if the APRI suggests that they have cirrhosis.
Right.
So I think that's an alternative.
So it's an alternative, yeah.
Yeah. You don't need to wait for that result, but if you're planning to use FibroScan, you need to do the FibroScan before or within the first few weeks of starting treatment.
The first few weeks. So if you were confident they were going to go and have the scan, you could perhaps get started. Yeah.
Yes.
Got it. There's a comment here from someone who I'm guessing must be a pharmacist, who is commenting that at each dispensing, patients are sort of counselled about interactions
Yes.
and you know, actively looking for that, which is really reassuring, I guess, from a GP perspective, that you know, you've got this ongoing check. So that's wonderful. And I know the APRI pharmacies, we've got the link. They're actually on the health pathways, as Ed said, but we will make sure that they're available. Oh, great. Here we go. So that's really good. A couple of other treatment questions specifically about interactions. Some of the obvious ones, I guess, paracetamol. Is there any?
No, that's fine.
No interaction. That's great.
Yep.
There was another one that I thought, oh yeah, that. Oh, inhalers. I think that must have been mentioned on one of the slides.
Yeah. I don't think I mean, there is a small dose of steroids in the inhalers, in some of the inhalers. I don't think that's...
No, I think that was certainly an issue for Viekira. That some of the commonly prescribed asthma steroid inhalers you had to change. It's not an issue for Maviret.
Oh, that's
so Maviret is much simpler. As Richard pointed out, that the two common interactions really are atorvastatin and simvastatin, and the combined oral contraceptive. And other than certain HIV medicines or certain anti-epileptic medicines, there are very, very few drug interactions in primary care.
Yeah, I think the steroids prednisone, I think.
Prednisone, okay, so yeah.
So
just bearing in mind
that more Viekira. I need to check.
Is that okay?
Will be on the interaction checker anyway. I guess we're sort of screaming through these questions, which is great. Patients who are non-compliant, you know, I guess that's sort of, we've covered that. If they're missing the occasional dose, it's relatively forgiving, so we may accept that and I guess encourage treatment, even if you're worried about the risk of that. And some more specific questions about different regimes, I guess. Epclusa, I'm not quite sure. I'm not familiar with that drug. I don't know what that is.
Okay, Epclusa is the other pan-genotypic regimen, which is not funded in New Zealand.
Right.
But some people have obtained Epclusa through the equivalent of Epclusa through the Fix Hep C Buyers Club.
Yep.
And because we've had no treatment for genotype 3 for a very long time, that was the only portal to get treatment, was to buy generic Epclusa through the Fix Hep C Buyers Club. And if somebody relapses after Epclusa, then they can be treated with Viekira, but they need 16 weeks.
With Viekira?
No, sorry.
With Maviret.
Maviret.
Yep, got it.
So if they fail Epclusa, they can be retreated with Maviret, but they need 16 weeks.
Excellent. Oh, that's good to know. And I guess, of course, you know, phoning in for some advice or doing a request for advice is our,
for sure,
our backup. Yeah.
And certainly we have our nurse specialists in the hospitals always welcoming requests for information.
And issues with renal function, I don't recall anything.
No, in fact, Maviret you can use in somebody on dialysis. In the big dialysis study, which we had several patients in that, the cure rates are exactly the same, 99%. You don't need to change the dose for people with any stage of kidney disease, even on dialysis. Yeah,
that's great. We've got a couple of posters that Richard's brought along. How do we access things like that, Richard?
So this poster here, which we've got up in our waiting room, is available from the last link on that's up at the minute. You can download that and print it out. And then we also, I don't like promoting drug companies, but I think that's quite a good poster from AbbVie as well. So,
that's great.
Those are two of the ones we've been using, as well as the one that Ed had on his slide earlier.
Yeah, all really good. A couple of final questions. Do you routinely check partners of hepatitis C patients?
We don't. Although we would ask them about risk factors. But no, we don't sort of check partners as a risk factor in itself.
Sexual transmission is not a risk factor for hepatitis C spread. certainly in a monogamous relationship, there's certain, I guess, scenarios where you could potentially spread hepatitis C if it was traumatic sex, but it's not regarded as a significant risk factor.
Oh, that's good to know. Would you encourage community support workers to be checking for risk factors? You find that useful?
I think the more people who can ask about risk factors, the better, and I think that will help to overcome some of the stigma associated with it.
Yeah, absolutely. Well, look, I think we'd better wrap things up. I really thank you all for all your questions, and a big thank you to both of you, Ed and Richard, hoping the sound's okay as we're sort of crowded around the little screen, so hopefully we've come across okay. But a big thank you to everyone who's written in, and apologies if we haven't got to your question. Hopefully the answer's been covered somewhere along the way. We'll make all of these links available, and other things that we've talked about with the posters as well.
And could I just say that in the first 6 weeks of Maviret funding, the uptake of treatment has been unprecedented. You'll hear soon about how many people who have already started on Maviret, but the numbers are far and away above what's ever been prescribed before, with almost well over 200 people starting Maviret every week, including a large proportion started in general practice. So I think it's already happening. I think as people find out just how simple and effective this treatment is, I would hope that would stimulate increased awareness and treatment.
I wonder if we might, is your last slide next, Ed?
Oh, no, you have to go the other way.
Oh, other way. Right. I'd just quite like to share with you the last slide that Ed has brought in.
Okay.
Because it's such a great shot.
This is a patient who was cured. She got her cure result last week, and she took this photo. She said, please use this in any promotional activities you do for increasing awareness of hepatitis C. I've never felt so great.
Isn't that wonderful? I think we'll all feel satisfied seeing a patient behave like that after we've given them some treatment. Great. Well, look, on that note, we'll call it a night. Thanks again for tuning in, and we'll catch you at the next webinar. And thanks very much, Ed and Richard.
It's a pleasure.